Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Tonight's topic, optic nerve and retinal rounds from nerve-wracking to nuanced. And our speaker is Dr. Drew Rixon. He received his Doctor of Optometry degree from Pennsylvania College of Optometry and completed his postgraduate residency in family practice at West Tennessee Eye. Dr. Rixon is currently an attending at the Memphis VA Medical Center, as well as a consulting faculty member at SCO. He's a fellow of the American Academy of Optometry and a diplomate in glaucoma within the American Academy of Optometry. He's a member of the Optometric Glaucoma Society and on the executive committee of the glaucoma section of the Academy. He's a frequent lecture, author, and peer reviewer. He is on the editorial board of Clinical Refractive Optometry and Clinical Insights in Eye Care. He's also been an active participant in VOSH and has many medical trips to the Caribbean, Mexico, Central, and South America. He has a great insight, a great presentation style, a really, really super nice person, and a great educator, and credit to our profession. So with that, a nice, warm, virtual OEC welcome to Dr. Drew Rixon. Drew, take it away and edutain us.
Well, thanks, Joe. That was a really awesome introduction, and I'll try to live up to it. I appreciate you, Greg, and Vanessa having me on, and everybody in attendance. I know a lot of us have had pretty long days, so we'll try to make this as edutaining as possible here. You know, optic nerve head and retinal rounds from nerve-wracking to nuanced. It really, as this has morphed, because this is, I think, the second time I've presented some variation of this, it's morphed into more of an optic nerve one. And there are some retinal cases at the end if we get to it. What I particularly like about having the opportunity to speak with you all, with Greg and Joe, is this will be interactive and we can kind of pick each other's brains, because the goal obviously is for us to all learn together, even if I'm the one primarily steering it. I have no financial disclosures on this talk whatsoever. The goal is, obviously, like the title says, we're going to discuss a variety of optic nerve and posterior seg cases. We want to reinforce the necessity of multimodal imaging in the diagnostic sequence. And so, with 61% of y'all having OCT, it's going to be entirely applicable, but multimodal is just an umbrella term for using different instruments to better understand the individual cases that walk into our offices and help us guide management and kind of inform us. And then we'll try to provide updates on changing nomenclature on a couple of variety of cases if we do it. And that's just a constantly evolving things. And I'll be honest with you, even though I'm up here lecturing, it is sometimes overwhelming trying to keep up with all the advances in our profession. So again, I applaud everybody for being on tonight, and just do your best to learn as much as possible. I remember listening to a lecture by Jimmy Bartlett years ago, and he said, if you learn 3 things from this lecture, I've accomplished my job. Okay. So we don't need to come up with, just groundbreaking stuff here. What I think it's really important to emphasize is the fact that when we're all communicating with each other, we want to be making sure that we're speaking the same language. And so I'll run into circumstances where one professional, even within the same profession, is trying to communicate with another professional, and they're just not saying the same things. It's like Tower of Babel sort of things. And so when we're talking about IVFA, it's fluorescent. When we talk about FAF, it's autofluorescent. And each of the individual descriptors or nomenclatures are indicative of what you're doing, and what you're doing makes a difference with how you're diagnosing. So I think that's really important. I want to kind of just say, hey, this plug for that review of optometry journal from a couple of years ago, where they just talked about the OCT as being the Swiss Army knife. I think it really is, and there's a lot of different facets of that. But just because you don't have an OCT doesn't preclude you from being able to comprehensively diagnose and manage in your practices. So we're going to start out with case CB. So case CB, I'm at the VA. She's a Marine. She's tough. Her email is something like toughmarinewoman@hotmail.com. She's probably still got like a Hotmail account. And I'm a tall, skinny guy, and she will kill me if I screw this case up. Okay, and she's super funny. I've been seeing her for years, but it had been a little while, and she comes in. This is how she presents. So she comes in with reduced vision OS. And we know history is the most important thing you'll ever do. Like you can count on your hands, the number of times someone complains of that per day. That's probably 90% of our complaints is I've got reduced vision with my glasses, or without my glasses, which is even the better one. And so we have to qualify that by doing a good history. And that happens over time. There's a whole bunch of mnemonics out there, but we just want to think through the process, and it evolves as the exam goes on. So when we look at the characteristics of this, she's got slowly worsening or insidious reduction of vision over the last 8-10 months. We only do medically necessary contact lenses at our VA, so sclerals, things of that nature. And so she's getting soft spheres or soft multifocals over at the outside practice. And she goes to the outside practice, and the doctor who used to be a faculty member at SCO says, hey, your vision's down. I think you need to get more comprehensive testing because we don't have all those tests that you need in this office. Being the tough Marine chick that she is, she's not going to go ahead and do anything for a while, and it gets worse. So much so as a week ago, she covers up her right eye. We're working in a binocular environment, and she covers up that right eye, and the left eye can't see cars in front of her, but has periphery intact. So she has this central defect. She's got tinnitus. Is that a confounder? Does it actually matter? History of migraines, there's no worsening of these, and then medications that may or may not be pertinent to this case. So we look at this, and the vision was 2040 when she went in for a contact lens fit a few months ago. It's now down to 2150. She supposedly has a 1+ APD OS. I was taught in school that you can't see a 1+ APD with the naked eye. You need to use neutral density filters. Either way, there's some dysfunction that occurred, and the resident didn't get me before dilating, but you'll see that this is clearly legitimate. It's probably a 2+ APD. Amsler grid is reduced. Color vision is unremarkable. And then she's got a history of optic nerve head drusen. So that's another thing that layers this and makes it a little bit more complex, trying to understand what's happening here. Previous photos are going to be to follow, and the OCTs were unchanged at the visit that we saw her on. So let's look at the disc photos. And when I presented this in Nashville, Greg was talking about the different compositional aspects. What you can see there is very obviously these are disc drusen. I could get an applicant coming into an optometry school that's never seen a nerve and ask them about contrast, and it's like, yeah, there's something different about this. So there's nothing difficult about the diagnosis, and we already have that information here. Let's look at the RNFL. If you don't have an OCT, simple categorization or understanding when you're looking at scans a lot of times defaults to colors. That was the lecture I did last month on green isn't always clean, but what you can tell is that this RNFL, this neural tissue, is really, really reduced across the board, and that's pretty consistent with the level of drusen, and we'll talk about that. So when you have a situation where it's hard to capture neural tissue because the tissue is so thin, you switch over to other areas of the eye that can be captured, namely the GCL or GCIPL or GCC plus, anything ganglion cell that's also the neural tissue. And you can see that that's also reduced on this color scale here. You have almost like a double arcuate pattern. And we'll move on from that. When we go to our cross-sectional scans, and again, when we're talking about OCTs, we want to very much define what we're ordering on the front end to understand what we're trying to capture, right? So in this case, we did a dense, I think it was a 48 dense with enhanced depth imaging, which we'll talk about. And what you can see is you have these hyper-reflective borders, hyper-reflective centers, indicative of drusen. The historical visual fields, you can see she's got a double arcuate, just to put it very, very loosely here on the left eye. And on the right eye, you have also arguably a double arcuate, but more of a superior arcuate there. And when we're looking at fields, we always want to make it easier for ourselves. We want to do the patient view. So the left field over the left eye, the right field over the right eye. The visual field on the day of the exam here is worsened, and you can see she's having some problems with how she's tracking because her vision's reduced. When your vision's reduced, you try to change your stimulus. And so we went up to a large diamond pattern, and even then she had some problems. Now, the grayscale you probably were taught in school is trash. You don't ever want to use it, especially when it comes to glaucoma. I've been to many, many lectures where people back in the day, the lecturer would talk about printouts, right? So everything's digital now. But back when we used to print things out and you'd kill 19 trees to get the overview, they would always say the only thing the grayscale is good for is me placing my cup of coffee down. But when we're talking about neural disease or acquired situations that are relatively acute, and I get that this was a relatively insidious how this played out, but in these relatively non slow situations, you can use the grayscale to see if there's a marked change. And you can see that there's a marked change 1 year prior to today. And then I have that down there. I think I'm blocked as far as the VFI is concerned, but the VFI is a center weighted thing. And it just gives us an idea of what the field is doing. And so she's lost a lot of sensitivity over that year. So what we have to ask ourselves is the age old, Occam's razor versus Hickham's dictum. Do you have a very simple answer to this? And is this staring you in the face because you already have it? Or are you going to have something that's more complicated? And in general, you want to make things as simple as possible, but no simpler, because if you oversimplify, you're going to miss some things. So this is a paper from 2019, which does a really good job just enunciating the various types of drusen, the different volumes, the different field defects. I think it's something like 85% of patients with drusen actually will have field defects. So how does this play out? But in this particular case, in this 44-year-old with insidious vision loss in the one eye, I don't think that's it at all. I think this is very unlikely to be drusen related to, and we'll get into that. So in a hospital setting, we're blessed with having the opportunity to just have multiple disciplines available to us and also multiple imaging modalities. So we walk over and we talk to radiology, and specifically we say, okay, we just want to go ahead and get a CT on this lady, and you have to figure out what the flow of radiology is on that any given day. And so we go over and we do the CT, we walk her in. And so when we look at CTs go off density, going back to our nomenclature. And so we look at this and we see that CTs go off density and they look at how much attenuation of X-rays there are. So bone really, really, really attenuates. Okay, so you're going to have hyperdensity with bone, but you see in the sinuses don't attenuate anything. So you have hypodensity overall. And you can see the drusen right there. But we look through here and you look at that area right there, that mass. It's a very obvious mass when you start really looking at it, and it's a little bit more dense than the surrounding tissue. Okay, so this is what radiology says. They say, hey, there's a standard CT that was done. We did this without contrast, and that was at my individual order and request. This is just what was chosen on that individual day because we wanted to expedite. This was demonstrated a 3.2 centimeter suprasellar mass, which was homogeneous and only slightly more intense than the gray matter. So that's one of those, if you're looking at the nomenclature and you're listening to me a second ago, CT's density. So this board certified radiologist uses MRI terminology for CT. So kind of sad, but it just is what it is. We need to do better. And when we look at the midline, and again, to orient, the left side of the image is going to be the actual right side of the head, and the right side of the image is the left side of the head. So when I dissect through that midline, you can see probably 60% of this mass is over on that left side. So it's not shocking that this young lady is having issues compressive-wise on the left side. So at this point, the radiologist calls me and says, hey, because I have to put the order in our system, said, hey, can you put in an order for an MRI with and without contrast? I need to get more information. Always, and again, we're going back to the multimodal theme where we're using different instruments to better look at or get different vantage points on different things to better understand. Okay, so we're going to walk over the MRI. And so just a quick MRI recap, you'll hear T1 and T2 and flare and stir and spin echo and DWI and all these different things. And these are options that you can get on your MRI, and you have to decide what to order and not. But generally, we usually talk about T1 versus T2 weights. And this is just a nice little table to show things. a lot of times the mnemonic, like eyes too bright or like that descriptor, turns into like a T2. The easiest way to tell whether you're at a T2 or a T1 is just to look at vitreous. And vitreous on a T2 is going to appear hyper intense. But the reality is there are sequences that you can order, flare, that minimize the actual fluid and make them black. So the best way for you to know what you're dealing with is you want to look at the white matter and the gray matter. And on a T1, the white matter is going to be lighter than the gray matter. And on a T2, the white matter is going to be darker than the gray matter. And we're going to orient on some slices because I want to give you a couple of different coronals for us to work off of here. So what you have here, just going through this, is you have the gray matter is gray and the white matter is lighter. So that's a T1 coronal. Sorry about that. Now, when we go over here, you see that the white matter is darker and the gray matter is lighter. So you have a T2. And then when we go over here to this last sequence with contrast, you can see once the blood-brain barrier is disrupted, that contrast dye can get in there and you can help understand the properties of that individual mass. And then radiology can work with other subspecialists, say, well, this is what I believe this is, and we'll go from there. So we have to ask ourselves, is contrast something we want to work with? And are we concerned about contrast? Because, it's always like you hear these things and you have some concerns about lawsuits because it gets put out into the media. And, you have these used to be out where you have some ambulance chaser trying to see whether or not they can get one of your patients that you did contrast dye on signed up for a class action suit. Chuck Norris, like, do you want to piss Chuck Norris off? I don't know how old Chuck Norris is, but he could still absolutely take, I think, almost all of here. Well, his wife had a gadolinium for an MRI, and she had some brain fog afterwards. And the supposition was that the gadolinium ended up sedimenting in her brain because it can stay on. And so they tried to do the class action lawsuit a few years ago on that. And they ultimately ended up dropping it. The main goal for Chuck Norris was to raise awareness about the side effects of these contrast dyes. Well, the deal is in radiology literature, they've looked at this. There are older gadolinium contrast agents that are type 1. There are type 2 that are out. And some of these type 2 agents are much less likely to cause problems. A major concern, because these are processed through the kidney, was if the kidney was already damaged, was it could actually get worse if you did certain gadoliniums. And that doesn't happen with type 2 gadolinium. So the main thing with radiology in their world is they say, listen, it's more harmful for you to not know what you're trying to image or not understand what you're trying to image than the low likelihood of there being damage from gadolinium. So just keep that in mind, that if you feel like you need to do contrast, you need to do the contrast overall. And this is just what our ordering shows at the VA, where we have to see whether or not there's renal failure, and we need to have blood work ahead of time to make sure that there's no kidney damage whatsoever. And we're using a type 2, so there's less risk, but we want to make sure everything is safe. You go through the whole process, make sure that no pacemaker that's not compatible is there, no metal, things of that nature. So I just wanted to touch on that a little bit because I think sometimes there's a conversation or a question about, do I do contrast with or without? And most recommendations usually are with, depending on what the indication is. So let's look at the with contrast here, looking at a coronal and an axial and a sagittal, just to give you different vantage points, because you're going to get different information from each of those vantage points. And you can see you got this large mass, and all of these, again, just to underscore the fact that this is a flare. So this is a flare image. So, but you look at the gray matter is light, the white matter is darker. You have a T2, which is why trying to do the eyes too bright is not good enough. You got to go off white matter and gray matter if you're trying to understand what sequence is being used here. All right. And then you can see where that is location wise. I think I have some more detailed analysis on this. The other thing you could do is you can use the corpus callosum. The corpus callosum is lighter. That's going to be a T1. But there's a lot of areas that chiasm is being compressed on there. So it's not shocking. So the diagnosis here, based on the radiological imaging and its properties, is a planum sphenoidal meningioma. And so I just wanted to put in the surgical narrative because she had elective right orbitofrontal craniotomy resection within a couple of days. And you may ask, why is that considered elective? It's because it's a mass that's not going to kill her. It's going to blind her, but it's not going to kill her. So there's always that decision-making process because of pretty invasive surgery. But looking at the surgical narrative from neurosurgery, what I wanted to just show is as they got over to the left side, see how invested that tumor was into the optic canal. And so it's not shocking that we had this compressive situation. And we as optometrists were the first line on this case. And everybody on this lecture, all of us can take care of this. This is something that we just need to look for patterns and make the appropriate referrals, even if you don't want to do the imaging or order the imaging yourself. And this just shows again how jammed everything is. Back here where the cavernous sinus is, your CN2 is right there, your carotids, and then your pituitary. So these planum sphenoidal meningioma is just an anatomical descriptor, like where is this? It accounts for 5 to 10% of all intracranial meningiomas. That's a lot. 2% of all primary intracranial tumors. Females more than males. And again, epidemiology dies hard when the patient's in front of you, right? It doesn't really matter what the patient's gender is if they have something. Okay, but these are just overall averages that actually work out to the narrative of our patient. It's typically slow growing. And what you might say is, well, we got to this a little early, right? Because most patients remain asymptomatic until greater than 4 centimeters. But I think what's most important is not the size, but the location, right? So if you have something that's right over the optic canal and the chiasm, even if it's small, it could potentially cause some issues overall. So that's just the thing. This was a 3.2. But I cannot emphasize enough that the patterns that we recognize when we hear the reduced vision in one eye, you always have to kind of go with what could be the worst case scenario. And then you can quickly work your way back to, oh, it's just a slight change to their astigmatic correction or something like that. But we always have to have the right threshold in our minds when we're doing good histories. But 77% of patients, it's going to be us. We're going to be the ones looking at it and determining how things are playing out. And just to reemphasize the anatomy again, this is what the location of this tumor was. Had it grown anterior, maybe she's losing her sense of smell. As she pushed backwards and started causing some issues if it was secreting or something like that, because we did look to do whether it was secreting or non-secreting. We did blood work. There's always that possibility that something else could be happening. So it's all location based there. And that's just another schematic there to just show how close this thing was to the nerve. So pre and post tumor removal, you can see that right there. And I think that really nicely just delineates how much of an improvement there was for this patient from a physical standpoint. But more importantly, and what we really care about is look at the improvement on the field from this left image to this right image. And you look at the VFI, went from 51% that theoretically she's only got 50% of her visual sensitivity to 86%. And that's defaulting to the baseline of just the drusen overall there. And so her VA is now 20/20. That's what we care about. So if these masses are sitting there for a while and we recognize that the vision is reduced and we do nothing about it, there can be permanent reduction in vision. Now, some of these patients take a longer time to recover. The recovery, it can be delayed, it can be immediate, or it can be really, really prolonged up until like a year out. And so when you're talking to these patients prognostically, you have to say, hey, this is what I think is going to play out, but I want to go ahead and temper your expectations. So this was a big success overall on this case. I want to talk about again, like because I think Joe will talk about this with North American Neuro-Ophthalmological Society, that there's not enough neuro-ophthalmologists and probably not enough neuro-optometrists. I think this is something that we as optometrists, we know the anatomy, we're very well skilled from early education through our practice lives. We need to be able to order imaging if we're allowed to do so within our individual states. And a lot of times I got a case coming up where it may have been an insurance discrimination, not that we can't order legislatively. But if we're going to be ordering, we have to understand that we're part of the team. And I always say this, you're never alone on Optometry Island. You're never there. Okay. You can always pick up the phone, email. We teams over at the VA, believe it or not. You can text someone. You can always go ahead and get in touch with someone else that can help you. So when I was taught in school, I think it was like 1 out of every 5 images are read incorrectly by radiology. And that's a really, really, I think, a misleading number because it depends on the individual type of thing we're dealing with. I was looking at some articles on pancreatic cancer, and if I was in a hospital that was tied to the world renowned pancreatic cancer specialists and the radiologists that work there, they would never miss. But if I was in some general emergency room and the radiologist was trying to read someone that came in and the patient had pancreatic cancer and it wasn't known, that might be a huge miss. So there's context here where you can go ahead and change the odds in the favor of your patient. And I guess for you and your colleague in radiology or something else is you want to go ahead and provide context. So 70% of these errors are perceptual. The radiologist fails to see something, and they fail to see something because you just say, I want an MRI of the brain. Well, that's not good enough. You want to go ahead and order something specifically and provide the context of how this patient's behavior has been and why you want to look at certain areas. And then 30% are cognitive, where they just attach the wrong significance. So you really want to guide the radiologist when you're ordering, and then you want to pick up the phone afterwards. So a lot of these failed communication lawsuits, or these patients, these doctors that have been sued, that admitted it, that are members of the American College of Rheumatology, 25% were failed communication. So say internal medicine sent over to radiology, radiology did communicate back to internal medicine, and vice versa. Internal medicine made no attempt to go ahead and talk to radiology about the test that they ordered, and then the patient's dead. It's like, we got to talk out there. You got to do what's in the best interest of the patient. I think sometimes if we overly compartmentalize, we can have mistakes occur. And then we look at OMIC, which is the Ophthalmic Medical Insurance company that looks at claims. The number one payout was oncology. And again, we need to do better. And just, it's a matter of talking. I think it really is. And the only thing that's going to preclude you from having success in a lot of these cases, and even sending or referring in these situations, is your ego. And your ego doesn't really amount to success. You just need to do what's in the best interest of the patient. So that's kind of the setup, just to talk about Drusen, in all honesty. Anyone have any questions about that case? Joe or Greg, you got any insights or any statements about that case?
Yeah, Drew, if you can go back to your previous slide, I've got one more slide. I'm sorry.
This one?
No, ahead. In between. Right there. Bullet point number 4, I think, is, bears a little bit more emphasis. The world's best neuroradiologist can't help you if you didn't order the scan, order the right scan, and tell them what to look for. I don't read the MRIs myself, because what you don't know can hurt you a whole lot. I look at the report to see the right thing was done. If I have any questions, pick up the phone, talk with a radiologist. It's not challenging. They have atlases that they compare against. I had a patient who I suspect a lateral geniculate nucleus lesion on, and they had to go to the atlas, and they compared against the atlas and said, no, there just is nothing there. Next to the last one, if you order the test, you own the test. You are responsible for telling the patient what the results are and what you're going, and how you're going to deal with it. Now, I will occasionally get a call from a radiologist. Most of the calls I get from radiology is a question about performance of the tests, or if we can do something, or kind of the mechanics. Once in a while, I'll get a call from a radiologist when they see the results, And that's always bad. If a radiologist calls me, it's something that is imminently going to damage this patient greatly. Drew, could you go back one more?
Yeah.
You see how nicely that came out. Uh, a way you can predict this is the OCT. Now, in your case, it doesn't work because of confounding disease. But if you have field loss like this, but structurally, the OCT looks good on nerve fiber layer and ganglion cell complex, barring complications, there is actually a fairly good prognosis. If the OCT is damaged, and I said yours was damaged because there was something else going on, the drusen, prognosis is good. It's bad. But if you've got a good nerve fiber layer and a good GCC, even with this kind of field loss, improvement can happen. So that's something you can kind of guide on. Now, I had a planum sphenoid meningioma a couple months ago. And interestingly, the patient's history was not consistent the way you think. It was how she perceived it. She's almost exactly the same age, female, and she was complaining of, I don't want to say abrupt, but relatively recent and sudden loss of vision in one eye. And I can't remember what the details were that made me think this, but I knew it was not abrupt and sudden. And when I worked through her history, I got her to admit that, yeah, I've been having trouble with my contact lens. I keep changing my contact lens out. And she really had some reduced vision for quite a while that she never really actually paid attention. I said, is this sudden loss of vision or is this sudden awareness of loss in vision? She said, yeah, it could be that. And it was a compressive lesion. Now, interestingly, I've got a neuro-ophthalmologist who works with neurosurgery, and I give him the right of first refusal. And he and the neurosurgeon took a look at it, and they declined to do surgery. Too much risk where it was with the internal carotid artery and the chiasm and what it was doing to both those structures. So ultimately, I had to get it to a guru skull-based surgeon at the University of South Florida. So these things, it's hard. It's hard to deal with, but it's a great case, Drew. That's it.
Yeah, no, I think the anatomy speaks for itself. And I think you made a lot of good points there. I mean, is it acute awareness of a non-acute thing? I think that's always important to talk about. And then even though we're not going to get into I'm not doing any NAION, or I've got some swollen nerve stuff. Prognostically, when the nerve is really swollen, you really want to look at the macula because it's usually less swollen as a generality. So no, really good tips. And the only other thing I would say is that I'm a big proponent of kind of like what Joe said, is picking up the phone. And I think if we just stay in our shell in our offices and don't pick up the phone, we're really restricting ourselves from improving and also taking care of the patient. So it may seem intimidating on your first call to these people, but they don't know a lot of eye stuff most of the time. So, don't be intimidated. I cannot emphasize that enough.
And I'm gonna triple emphasize that, and I want people to know how that call goes. I have a 6'11" MRI. I've pretty much got to know the docs there, but back whenever I started, I was a little nervous. You're right, intimidated. I would call over and I would just say, "Hey, look, I have a visual field here. Inferior quadrant. That's telling me that's in the parietal lobe. I don't know if it's a mass. I don't know if it's ischemia, but I'd send the visual fields over. I'd walk it with the neuroradiologist, walk them through it. They're like, "Oh, this is really cool. I get it now. What I'm looking for." Da 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 da. So, I mean, that's kind of how that conversation goes. I look. I ordered the MRI head and neck and with and without contrast. Let me know if I need to be thin slices or this or that. I'm kind of checking my order, but I'm also letting them know what I'm looking for. So I'll echo making that phone call.
Yeah, this past weekend at our live event in Pittsburgh, an older practitioner came up and was talking to me about that. And he was very frank, said, I'm afraid, I'm still a little afraid to call NMD. I said, look, we're all doing the same thing, trying to help somebody else. Trying to help out the patient. I had to make 2 calls just today to get care arranged for these neuro-op patients. Hey, Drew, there's a question in the chat. Since you regained most of her vision, how long would it typically take a compressive lesion to leave permanent damage?
That's a good question. I don't actually have an answer for that. Joe, do you know? Like what? I think that would be on an individual basis.
There's nothing there's
No?
nothing that we can say definitively. Lori, it comes down to it depends. Depends on the type of the mass, how quickly it has grown. I've seen things that have been there for really significant amount of time, and when removed, vision comes back, and other patients don't recover anything at all. The
Yeah.
nervous system it can be very touchy.
I mean, I will say this: the only thing I did see in studying up was that they've actually done, as far as recovery, they've done VEP on these patients, and removing the mass. They've found with VEP, 10 minutes after the mass is removed, there's complete recovery. And then there's other patients, like you said, Joe, where it's like outwards to a year, and there may not be recovery. So it's a great question, and I think that when you're talking to a patient in any of these circumstances, you just have to temper expectations. And I think when you have these cases, if you think that the vision has reduced, I think I get this from dermatology and radiology. It's like, hey, if you're not sure if things are okay, sometimes it has to evolve. So if it means, hey, I'm going to wait a month and recheck their vision before I start going way down a crazy $10,000 workup, I'm going to go ahead and do that. So I think the main thing is catching something that's a red flag. And if you're not going to go ahead and do a major workup that you think is way overboard, you watch it. You contract your intervals as you're watching these patients, and then you adapt accordingly. And then hopefully you've done it in a way that there's not permanent visual defect. So I don't know if you guys have any insights on that, but I think each case is so individual.
Yeah. My threshold for evaluating a patient is very low for what I consider what I do. I ordered myasthenia testing twice today. I ordered GCA testing probably twice a week. My threshold, if I get a patient who's got complaints that I can't satisfy, I won't hesitate to get neuroimaging. Now, you did mention some medical legal things, Drew. I can tell you, I've done probably over 100 cases as an expert witness, and I just recently had an epiphany, and I'll tell anybody who will listen. In those 100+ cases, I have never been involved in a case where an optometrist being sued did a culture, ordered blood work, or got neuroimaging.
I've got some slides. Got some slides going down that direction in a little bit, actually. So that's a nice segue there. I guess I'll move on, but no, great discussion and great questions. So optic disc drusen, again, they're acellular deposits of calcium, amino, nucleic acids, mucopolysaccharides. If you're big into the histology, again, I think the number is actually down here closer to 85% will have visual field loss. So I think that there's this, I used to kind of blow disc drusen off. It's like, oh, it's a disc drusen, move on. At least now we'll get fields and baseline OCTs, and we can talk about that a little bit more. But a lot of patients, because they've adapted, they're actually asymptomatic, even though they might look really bad. So this is our first poll question: is what is the best way to diagnose optic disc drusen according to the Optic Disc Drusen Consortium? And this has been out for some time, but I still don't think it's made its way down to everybody.
Yeah, Drew, echoing what you said, beware the symptomatic drusen or optic nerve head hypoplasia patient. Beware the symptomatic amblyopia patient. Those are three types of patients that are not supposed to be symptomatic.
That's the age-old, don't just diagnose amblyopia because it's convenient. You have to have an amblyogenic factor always.
And while this poll was running, one of the things when you mentioned that about the morphology there, Drew, is what I want the audience to point out is that these are totally different than macular drusen, right? Macular drusen are inflammatory. It's a C5 overreactive immune system. This has nothing to do, even though it has the same name, drusen, these are morphologically totally structurally different. So
It's a great point. It's a great point.
there you go, my friend.
Sweet. Very good. That's good. That's really good, actually. So good job, everybody. Because we'll talk about this here. Let me see if I can get this off my screen. I'm gonna have to take that laser pointer down. Okay. Let's keep going here. Okay, so disc drusen diagnostics. I mean, I certainly hope you would not be spending the money to do a CT, but a CT would show that you have hyperdensity there, and the density is only slightly less than bone as far as the drusen really attenuating the X-rays there. When we look at FAF, I cannot underscore enough, if you have an OCT or if you have a camera that has autofluorescent capabilities, it's really, really a powerful tool, especially with inherited retinal diseases, especially when we're looking at reticular pseudodrusen or subretinal drusenoid deposits as prognostic indicators in AMD. And when it comes to autofluorescence, essentially you get the fluorescent properties without having to inject dye into the antecubital space or a palmar vein or whatever. I'm saying it's non-invasive, and some of us don't have the capabilities of doing fluorescein angiography, nor does it even make sense from a cost standpoint. So what is done with FAF is, in our instrument on the spectralis, and I have no commercial interest in anything, I'm just saying what we have, is they use blue light, and the blue light will excite fluorophores. So we're talking about ocular fluorophores. So generally speaking, when we talk about fluorophores in the eye, we're talking about lipofuscin, but in this case, it's extracellular mitochondria. So the blue light will excite these extracellular mitochondria, and there will be energy emitted, and the machine will capture this and they'll render it as a brightness map. Okay. And that's what you see here. And this is something that you'll see in drusen that are typically not buried or deep drusen, they're superficial. So an FAF is a really good way to kind of enunciate how much volume of drusen is there and where it's actually playing out. So just a great technology that if you're not using, start using. When we look at B-scan, and B-scan was the traditional gold standard. So B-scan uses echography. So my son was having his physics test coming up in 5th grade. And it dawned on me, like I was trying to work too hard to understand echography, specifically B-scan. They had a test question. It was like, okay, what gives the most echoes? Okay, because if I have a hyperechoic situation, I've got a lot of echoes. So do I have more echoes in a padded room? Do I have more echoes in, like, I'm out in the forest? Or if you drop me from a helicopter into the Grand Canyon and I'm yelling at the Grand Canyon? So harder substances are going to have more echoes. So when you have something harder like this, it is going to be hyperechoic. And so what we used to do is we would turn down the actual intensity of echoes that were going into these eyes. And if you turn down the echoes, things that were hypoechoic or less echoic would kind of disappear. And then the hyperechoic entity would show up, and bang, you got a B-scan. Or you got a drusen there. And so that's what we used to do. And then when you're also doing these things, you want to look at A scans because it's multimodal. That's our premise. And that's going to be a signal peak, or you have a hyper-reflective situation. So that's used to be the gold standard, specifically in kids and specifically in buried drusen that you could not see clinically because it would be maybe the only way to capture it. Nowadays, the gold standard is actually using your SD-OCT or just swept source, but with SD-OCT using enhanced depth imaging. So this Mickey Mouse looking thing is what you're looking for. You have these hyper-reflective edges or surround barrier in this hypo-reflective center. What I always found when I first started looking at these OCTs, trying to find drusen, is I had no clue what I was looking at. I was so disoriented. then you have to understand what the different shadowing characteristics are. These are blood vessels. Blood vessels have a very discrete shadow, and that can really make it difficult if you don't know different properties. I've seen a lot of cases that I look back and it's like, man, I had no clue what I was doing early on because I didn't understand how each of these individual component parts of the eye actually behave from a reflectivity standpoint. If you want to flip the script, you can do either white on black, which is traditional, or you can do black on white, and you'll get different information there. So that's a classic drusen. Now, they tried to turn these into 3 categories of drusen. And so what you see here is on the left, you have something called a PHOMS. In the middle, you have these granular, hyperreflective, linear kind of units. And on the right, you have these more confluent drusen. So this is not a drusen here, not a drusen here. That's an actual drusen. But in all the individual early studies where they're trying to understand the behavior and try to use the OCT to determine what's actually there histologically, there was a learning process that occurred, and it took a little while to understand. So do you have a PHOMS or do you have a problem? Well, so my colleague is a fantastic retinal doctor.
All right, Drew,
Okay.
I gotta pause you for a second because
Yeah, go
when
ahead.
we get when we get our surveys, we always talk about these acronyms like everyone knows what they are.
Yeah.
So you gotta do a
I'm actually
PHOMS for.
My next slide is gonna break it down.
Okay.
Okay, so,
All right.
so yeah, no, the acronyms get crazy, right? It's like how many acronyms can I keep up with? So I'll break that down with this PHOMS.
Thank you.
So my coworker does mostly retina. He's in the Optometric Retina Society, lectures for them every year. So he brings his 15-year-old daughter in. She's not a veteran, so he sneaks her in. And again, we probably shouldn't be saying this. He brings her in for an eye exam. She's little. He's a smaller guy as well. She's got occasional headaches, no pertinent medications. He looks at her nerves and it's like, oh, this is really, really bad. I'm really, really worried. I know too much and I'm scared about my child. Okay. So we look at the green isn't always clean, but like hyper green in this case, and not hyper green, 96th percentile for the reference database is pretty thick. She's 15. She's not on a reference database, but she's got very, very thick RNFL, very, very thick, 538, 670 over here on the mean minimum rim width. So you have to ask yourself, what does she have going on? So we try to put component parts of our OCT together. We want to look at the topography. We want to look at the colors for patterns. And there's no patterns here that show anything abnormal, like Joe was talking about before, where you might have prognostic information where this was diminished in a way that you think the patient's going to lose vision. But you see all that white there, it's a seemingly swollen nerve, or at least thicker than average. FAF is done, and there's no drusen whatsoever. You can see that it's thicker on that nasal side overall, especially on the inferior nasal side. And this is what we have. So, Greg, we're going to look at this and we're going to say, okay, do we have a PHOMS or do we have a problem? So we're going to circle over here and we have to ask ourselves, is this parapapillary? It is. And it's above the level of Bruch's membrane right there. Is this diffusely hyperreflective? So when we look at the categories, or we look at how we classify, we're using optical coherence tomography. So as I said in the beginning, it's reflectivity. So you have this pretty homogeneous reflective entity that is above the Bruch's and parapapillary. Is it ovoid? Yeah, you can argue it's ovoid, and it's not just because I drew an oval over it. Is it mass-like? And is it a structure? Yes. So what you have here is the PHOMS, and that's what it stands for: parapapillary, hyperreflective, ovoid, mass-like structure. I mean, good Lord, memorize that or say that 5 times fast. But it doesn't really matter whether you know the PHOMS as far as that acronym. It matters that you look at this and you know that it's not drusen, it's not a mass, and her nerve is not swollen when you're looking at the cross sections. So when we look at these PHOMS, there's all kinds of different theories about what they are, okay? there's a thought process that it's exoplasmic stasis, and then there's some breakdown. There's thought process that it could be herniation of the RNFL. It doesn't really matter. I think this is almost one of these things where it's kind of a read and react sort of thing. You see that, it's there. The nerve is most likely not swollen, but it is associated with younger people that have smaller scleral canals, and they have a higher incidence of buried drusen. But you can imagine if you look in at your daughter's nerves and they appear swollen, that you would freak out as an OD who knows too much. And you might want to get someone else to take a look at that. So that's something that's out there in the ether with PHOMs, all these other terminologies that you might come across. So read and react. So there's this optic disc drusen study consortium, right? So there's all these major worldwide groups that get together to try to understand different things that they find on OCT so they can help inform us so we can make good decisions for our patients and not make mistakes. So what you see here is drusen. They are always, and I can't see all of this right now, but I'm just going to work my way through it. So optic disc drusen are always signal poor and always have a hyperreflective margin right there, okay? Whereas vessels, specifically arteries, you can see both the posterior and anterior aspect of these arteries will go ahead and shadow in a very delineated way. Veins, you usually can't see the backside of them. But with drusen, you have this hyperreflective border and this hyporeflective center. Now, the reason I have not given the updated publication or put this up here is I want to point out to you and to that when we're reading, if we're reading a trade journal or we're reading an article, major publication, there are mistakes that are made all the time. And we as astute readers can look at this and we can say, hey, wait a second. I just read through this entire journal and it said that it was supposed to be a hyporeflective core. Did I screw up or did they screw up? They made a mistake here. And you're not going to have the time or the wherewithal to wait 6 months for there to be some retraction in this journal article to be updated. Okay, so just trust your instincts and know that sometimes things are wrong and you are actually correct. There's nothing wrong with that. So again, these drusen are going to be hyperreflective margins, hyporeflective center. Okay. And that's just the mistake that gets made sometimes because it's tough to proofread everything and get publications perfect. So the consortium protocol, because there's got to be a way that you're doing it. You want to use your STOCT, you want to use enhanced depth imaging. What is enhanced depth imaging or EDI? Well, they found a number of years ago that if they pushed the instrument closer to the eye than was the standard plane, the image would invert. And at the top of the image, they would actually be able to see choroid and sclera in a lot of cases. And that overcomes the problem with buried drusen because drusen are always anterior to lamina. Okay, so you want to use enhanced depth imaging. Most of you on your SDOCTs have enhanced depth imaging capabilities. If you don't, you can push a little bit closer to the eye, but you're going to look at it upside down. So the choroid is going to be upside down and it's going to look a little weird to you. You want to do a lot of imaging. You want to do it very dense. And you want to dilate because I didn't mention when we were talking about autofluorescence, there has to be enough blue light excitation if you're using blue light. And the pupil is a boundary there. That entrance pupil limits the amount of brightness that can actually be culled there. And so this is a good case where if you don't use enhanced depth imaging, all you're seeing is this anterior border. And so you don't really understand what you're dealing with. Maybe it's like, go get the B scan. But if you use enhanced depth imaging, see how you can have shadowing here and you don't get much detail. But look, you can see the choriocapillaris. Choroid's not really well enunciated. And then you can see sclera down here, and lamina is usually at the same plane of sclera. And so you can see the posterior aspect of this. And this is just a massive drusen that we're seeing. And so,
hey, Drew, before you go too far, can you go
Yeah.
back like one more image? I don't want to steal your thunder. Keep going back. Keep going back. On this one here, because I'm sure you're going to talk about optic nerve head edema. Can you show how that RPE is deflecting downward there?
Yeah, right here.
Yeah. And, a lot of people might wonder, how can you tell another way if that's edema? if that's edema, it kind of bolt goes upward. So that one's still kind of pushing down, and the same thing on the other side. It's kind of going down. So
No, that's a great, and I will try to get to some of those slides. Everything with OCT now is trying to look at different markers on these OCTs to see how the pathology should play out. And then if we see certain things, like Greg says, where this RPE is going downwards, if I have CSF pressure, the CSF pressure, I mean, the volume of the brain is limited, right? I mean, that's why the skull is there. There's limited space. So if CSF goes up and up, there has to be some pushing out. So if there's pushing out, there should be deflection anteriorly, as Greg said, with RP and specifically Bruch's membrane. So we'll talk about that if we get to it. I think we probably will. What I will say is that these days, time domain is what it used to look like. And there was all these different things. They used to about the lazy subretinal hyporeflective space. And that wasn't all that useful, or isn't all that useful these days. But at each stage of evolution with our imaging, we get more and more sophisticated information, which unfortunately leads to more acronyms that we need to memorize. All right. So look how much it's gotten better. And wow, like the SWEP source is absolutely incredible. And some of the SDOCTs, like the Solix, which is OptiView's latest one, I think is up to maybe 110,000 or 120,000 A scans a second. So you're getting near SWEP source information. So let's look at the RNFL problem. This touches on something that Joe talked about earlier. If you have a case where you have drusen and it actually looks like the nerve is swollen, but we're going to first start off with the more drusen you typically have, typically the more RNFL thinning you have overall. So this study grouped patients into grade 0 through grade 3. In grade 3 were smaller nerves that were jam-packed with drusen. So if it's jam-packed with drusen, there's a possibility of a more axoplasmic stasis. It's going to be thinner, and it's going to be harder for you to make determination of what's going on. So the RNFL becomes thinner as more drusen exist in a smaller space. And when we look at these reference databases usually aren't able to take much thinner tissue. It's closer to floor, but that's kind of an aside here. So this was a case where these nerves look, and I'll go over the Friesen scale in a little bit, they look swollen, especially over on this left eye. So if you have a nerve like this that is thicker than normal, it's in the white or it's in the green here, you may say, I don't know what's happening here. Does this patient have glaucoma? Do they have dysfunction going on? Is it pseudoedema? Is it just drusen? And what are the drusen actually do? And this is what Joe touched on before, that you want to get more information. So the more information is also looking at the GCIPL, and this was a serious case that they had. And when you're looking at GCIPL, you want to look for patterns. Remember, the horizontal raphe is here, and these nerve fiber layer bundles come in an arcuate pattern like this. So you have dysfunction, even though the nerves seem to be elevated, they're not actually swollen here, and there is actually some dysfunction. That's due to the drusen. In this case, I don't have all the details on it to go through, but just make sure that you're using more than just the nerve. You got any other points on that, Joe or Greg?
No, I think it's very good. If you go back to the disc photos, look at the abnormal branching pattern. Do you see how it's not bifurcating, it's trifurcating? To me, that is a sign of an anomalous nerve more so than an edematous nerve. But of course, anomalous nerves can develop disc edema.
And that's the classic thing is supposed to be with drusen, and I'm not saying I see it all the time, is like wheel spoking, like it's a bicycle wheel. So that's a great point on that. I didn't get into that. Okay, so pros and cons of drusen diagnostics. The gold standard used to be the B scan because you were able to image deep drusen. Well, now with EDI, OCT, you can get to that. So if you have a kid that can get into your OCT, again, because usually there's evolution or protrusion forward or migration of those drusen in the teenage years, you should be able to capture that. If it's a kid and they're not able to get into the OCT, then the B scan still has a lot of value overall. So pseudo versus true edema, this was time domain OCT. They used to talk about that lazy V. Lazy V is not, I still hear this talked about. I think this is still like an easy question. If I was teaching a course, I could say, oh, which of these demarcates swollen nerves versus non-swollen nerves, lazy V versus lumpy bumpy. It's just not really consideration with modern evolution of imaging. The one thing I will tell you, and Joe touched on this before, is just because you have drusen doesn't mean you can't have some intracranial process that is causing an increase in CSF. So you can't just set it and forget it and be like, oh, I have drusen, the patient's fine. You still have to have a pretty decent threshold to listen to your patient and determine if more is necessary, especially in a confounding case like this. I think really our case that begun all of this is kind of like, in retrospect, pretty obvious because there was such a drop off. What if you didn't have reduced vision, but the patients had all these intractable headaches and positional changes to their vision and stuff like that, and they have drusen? So if you have optic disc drusen and they have symptoms of intracranial pressure, you're going to want to still image them. And I think I used to, when I was younger, I used to have a lot more respect for neuroimaging. And it may have just because I was in private practice and, I worked in, at the time, it was the third poorest zip code in the country. And so some of these patients, it's like they can't make their house note. So I'm taking it really seriously, whether or not we go ahead and try to bankrupt them by doing an MRI. But these days I practice in a different setting, but I think there has to be a happy medium where you respect that imaging is a necessary entity in a lot of cases. So I think it's just another tool in our armamentarium, and that's something we say all the time. So
Drew, yeah, I agree with you entirely. You need to consider this. I mean, if people are well insured or well off, it's one thing, and MRIs are not as expensive as they used to be. Probably $300 to $400, and you can probably make deals with a center. But I remember years ago, I had somebody neuro image that came back normal. He wanted me to reimburse him, and my response was, "Hey, well, maybe next time we'll be more lucky. It'll be a brain tumor. How about that?"
It is always hilarious where things have gone with the general public and doctors. Although I do still think that we are respected for the most part, but that's hilarious. Mm-hmm. I've got other stories, and we'll leave those alone. This touches on what Greg was saying, with using the SDOCT or SWEP source for biomarkers. So you see, again, as we talked about, if there's an intracranial process that's increasing CSF and the fluid has nowhere to go, there's only so much drainage that can occur, so it's pushing out, is you're going to have distension of the papillary and peripapillary nerve fibers, right? So with an increasing disc edema, the normally transparent RNFL thickens, and then you have the blurring of the disc margin. So we talk about wrinkles and folds and creases, and specifically this angular displacement of the BML, as Greg was talking about. So any of these top images are considered to be normal. So look at that yellow line, and Brooks membrane opening is here, but Brooks membrane is right there, okay? So you see that if I have a flat configuration or a V configuration or another V configuration, most of the time those are normal. So if a patient comes in and you say, I think these nerves are swollen, about 70% of the time, that's probably not going to be a problem. But 33% of cases of papilledema can actually have a normal configuration of the BML. So this is just kind of a starting place. If you have something that you don't think is a neuro-ophthalmological emergency, in theory, you could just do serial OCT and see how it plays out. And sometimes things have to evolve for you to better understand how to manage the case. So these are V-flat is what they're termed. Now, when you see what's happening, as Greg touched on before, you see the anterior protrusion that's nicely highlighted by the red here, where the BML is pushing up. It's almost like there's so much pressure going on. So this is considered to be a W right here, okay? An S shape and a dome shape. So if you have that, you don't need to necessarily worry about subretinal hyperreflective space and all these other things. You're having displacement, and displacement is abnormal. You need to do something about that. So these are patents folds going into the wrinkles and creases. And there's actually some cases out there, and I need to kind of consider this, where drusen patients actually have had some symptoms and they will have wrinkles, and wrinkles don't occur in drusen cases. So when we're talking about different imaging modalities, one imaging modality is something called ENFAS. And ENFAS is if you were to look down on that image and then you'd have to turn over and you'd go ahead and get a slice. So like you'll see that the most on OCTA, and some of these other instruments will have them, where you essentially take a slice and then you pop it up and then you're looking at it. So you could isolate just vitreoretinal interface or just superficial vascular plexus. And so if you were to isolate just the interface, vitreoretinal, or just the RNFL here, you could see wrinkles on that. And that would be, obviously this is a color image, but that may be a good thing to do on your drusen as well, just to make absolutely sure that nothing else is happening. So these wrinkles, folds, and creases, oh my, you have patents folds here. They're peripapillary wrinkles, high water marks, inner retinal folds, full thickness folds. And the one thing I want to say about this full thickness folds, the orientation of your scan should not be horizontal, because you're going to miss out on that. You want to go ahead and go across that and do vertical slices. And us not doing vertical slices a lot of times results in us missing some things. You can see those choroidal folds. So all of these can be indicative of problems. Okay, next poll question. I consider my OCT to be a neuro-ophthalmological monitoring device. True? Or like, hey, like, what are you talking about, Rixon? Like, I've never even considered that ever before. Or just false, my OCT has nothing to do with it. Because I think there's been a paradigm shift in how we use that. It really is a jack of all trades. And it's
So as this is rolling in here, this is a great time. We had someone ask about how accurate is the normative database in terms of age at present.
okay. So it depends on the instrument. I would say it depends on, I'm not a stats guy, right? So if I look at the Cirrus normative database, I'm going to be off by probably 10 or 15 here. I think there was 275 patients. And I think it was split between ages like 18 to 85. So you might have anywhere from 10 to 20 patients per decade of life. And so you have to decide how impactful that is to you. I don't know if that answers the question or not. And,
Yeah.
so
One
you
of
can,
the things I'll point out about this normative database is that, remember, this couldn't be high hyperopes, high myopes. They couldn't have diabetes. So it was truly a normative database, no tilted disc, no obliquely inserted disc. So, when we're asking how accurate is the normative database in terms of age at present, I would just be cautioned that it is truly a normative database on a nerve that is, if you want to consider normal. And then when you start getting in longer eyes and axial length and shorter eyes, high hyperopes, it really does mess up the statistics. Macro disc versus micro disc, it always measures, in that same circle. So if your nerve is smaller, you got more retina. If you got a bigger nerve, you got less retina. From the edge of the disc. So just be careful with that normative database that's out there. That would be my 2 cents.
no, I mean, beautifully stated. I think, and I guess this is to a certain extent my fault because I've mentioned the reference database. I don't use the reference database in practice. I don't care. I'm looking at tissues and I'm looking to see what those tissue properties are. And I'm comparing tissues to themselves over time. And I'm looking at tissue patterns, diagnostically. Like if we're talking glaucoma, I'm looking at the nerve first. I'm saying, okay, the inferior rim appears to be damaged, and I'm looking at the macula, I'm looking at the nerve, and I'm looking to make sure that there's a pattern of loss consistent. So when the 15-year-old was put on the reference database, and there's no 15-year-olds in the reference database, and people say, well, just put them in as an 18-year-old. That shouldn't really matter that much. And I can take averages from studies that show, application of the reference database can help you diagnostically, but I don't really think we should put that much emphasis on the reference database in our practices. Awesome. 76% of you are using your OCTs as neuro-ophthalmological uh, monitoring devices. And I think this is like, again, the huge opportunity for us to work in our communities, our medical communities, working with neurology to kind of guide them. So awesome. That's really
You
cool.
know, Drew, the neurologists that I've spoken to in my area, they're kind of aware of OCT, and they for the neurodegenerative conditions, MS, and they said, yeah, should I be doing that?
It's like, no,
Yeah.
well, and that's you have to avail your skill set, avail them of your skill set, right?
Mhm.
Like they don't really need to spend that $120,000 or $60,000 if you get someone scaled back. They don't need to do that. You can help with them. And I think, as we get into some IIH cases, if there's shunt failure and stuff like that, most of the stuff's moving towards how do we use OCT as a biomarker?
Mhm.
What's happening with the shunt? And so that's where we can play in. And you're not taking on some huge scenario playing out. You're working with neurology. You're saying, hey, the OCT's changed by 10 microns, and that's abnormal. And we need to talk about this and the umbrella situation of how that patient's doing comprehensively. So I think that segues really nicely into this serial OCT confirms papilledema. So this is a case from one of my friends that practiced in Middle Tennessee. Really, really sharp guy. I used to teach with him over at school when I was full-time years ago. And he's got a really good practice in Middle Tennessee. So patient walks in, and we'll just kind of talk about this. So 36-year-old patient comes in to Middle Tennessee in the practice. He's in Manchester, Tennessee. If anyone knows where that is, about 50 minutes outside of Nash. And the patient comes in on a vision plan. And you know how these things play out. You're asking the patient questions. You're like, hey, you don't have this, you don't have this, you don't have this, after you've already looked at their entire eye and you're like, come on, please endorse that you have headaches. Patient's got nothing whatsoever. So here are the findings, right? So again, looking at patterns, and I think when we look at the near infrared image, which is always there, you can see this C cuff. That it doesn't matter reference database or not. They're like, that's like a good way to say, hey, patient, let me explain this to you. And white means really thick. And this is like essentially you got a volcano happening here, as you explain. And fields are done, and there's, in theory, no visual sensitivity loss. Not in theory, there's no enlarged blind spots, so there's not a functional deficit here. But this patient's got bilateral optic disc edema, endorses no neurological symptoms. So this was a situation, this has been some time where at the time, the medical insurance that this patient had would not allow ODs to order anything. It's not like you're in the middle of your Wednesday. And this is what I would always say the worst patient is. Everybody talks about Friday. For me, it was always my Wednesday. And it's like I was seeing 4 an hour when I was in practice. And it's like 2:15, and I've got 4 or 5 in the books. And the patient walks in, and it's like they get swollen nerves. You need to get imaging done. And it's Blue Cross Blue Shield. And you're trying to argue with a nurse as you're getting backed up that you need to order this test. You need prior authorization. This wasn't even the situation. This is like, no, you can't even order this test. Okay. So Jeremy sends this over to neurology. And so his town's set up in a way that I think a lot of small towns may be, where they've got osteopaths, they've got allopaths, they've got, PAs, and they've got ODs, and the allopaths hate the, non-allopaths. And so there's bias. So the neurologist gets this, referral from the OD, and this patient's asymptomatic, and they end up doing direct ophthalmoscopy, probably from maybe 15 or 16 feet away. Like as you see, if you've ever gone into family practice or internal medicine, they try to check your eyes and you're like, good Lord, there's no possibility. Oh, everything looks good. It's like, so the neurologist says, hey, I see no optic nerve head edema. It's like, and the neurologist is really good at O-scope or direct ophthalmoscopy or whatever your school called it. It's like, come on, there's no way that they saw anything. So anyways, they still end up ordering images. And so this is what comes back. So you have to decide which cerebellum do you want. And this is not a poll the audience here, right? So we look at this, we go back to reinforcing T1 versus T2. This is lighter colored with the corpus callosum. So this is a T1. And you see again that, we're looking at the pituitary gland right there. Cerebellum's over here. And so this is not our patient's cerebellum. This is our patient's cerebellum. So they talk about this McCray line that goes between the anterior portion and the posterior portion of the foramen magnum. And depending on what the location of the cerebellum is, kind of determines, how much herniation has occurred. So this is our patient. So, when you think about spacing and you think about the cerebellum, if the cerebellum decides they're claustrophobic because there's not enough space, the tonsils will kind of go down because it's like, I need more space in here. I don't have enough space. So like, let's kind of figure this out, y'all. So your cerebellum is claustrophobic in this case. So this patient was diagnosed with a Chiari malformation type 1. Again, still says, hey, I got nothing. I got no symptoms. Okay. Neurosurgery says she's asymptomatic. We're not going in and decompressing the foramen magnum. That's like a big deal. So let's not do this. So what about the optic nerves? We still apparently she's fine. The patient's lost to FOB for an entire year. Okay. Scary, right? Very good chance of visual morbidity in a case like this. So she comes back and she's like, yeah, actually, I thought about it and I want to admit to you that I've actually been having some headaches. And patients do these things. I don't know why they do these things. Like they don't want to burden us or they don't want to, I don't get it. But like, why would you not just tell me I have headaches when I asked you umpteen different ways to endorse that you have headaches? So let's go to the OCTs and see how that can be compelling in an interdisciplinary environment, especially if you're dealing with some bias against you. So when we look at the right eye from September to September, it goes from 136 to 141. That's averaging. So an averaging on RNFL noise is 5 microns. Okay. So is that exceeding anything? No. But when we look at the pixelation and the machine trying to warn us, it's like, yeah, that's a lot thicker there. Now on the left side, you go from $119 to 182. Like that's substantial. No one can say, even with a poor scan, that that's not a massive, massive, massive increase in the RNFL thickness that she's endured. The good news, I don't think I have the fields here. Her fields were clean. So she's very, very lucky. She's got a situation that in spite of her nerves hanging out, being swollen for a long period of time, there's not any visual morbidity that's occurred there. So finally, we get some relief. So the patient now says, yeah, I've actually been having these nonspecific intermittent. She didn't say this. I'd love for a patient to walk in and say, I have nonspecific intermittent headaches that are worsening over the last 1.5 years, doctor. But that's not something that's going to happen. So OCT serial analysis is sent to the neurologist, and the optic nerve edema you cannot refute at this. It's like I don't know what happened. This is like a major. This is on them. Okay, they could have done better. Now, because of the Chiari malformation, they didn't want to go ahead and do an LP, so they ended up doing more invasive direct intracranial pressure monitoring directly into the ventricle. So you have to drill in. You have some pictures of that. The patient's got a 33 centimeters of water. So we probably all got taught millimeters of water in school, but once I got out, everything always seems to be in centimeters. So just take that as you will. So the patient's diagnosed with IH, and the Chiari is non-contributory. You can talk about different ways to manage. You can do a caloric challenge. I was listening to a lecture the other day by a guru in IIH. She says sometimes she does caloric challenges and puts these people on 450 calories a day. But in this case, they start on acetazolamide. And so what you can see happens is she goes from $182 down to 97 with the Diamox started. And like, that's a substantial change. And fortunately for this patient, there was no actual visual morbidity. So we'll talk about Chiari. So there's, Chiari 1 through 4, and there's a whole bunch of different definitions that are out there. This is another thing that there's epidemiology, and then there's actual imaging. We think of like in cadaveric studies, how often there's pituitary glands that are considered to be incidentalomas, where they're just found and they didn't cause any issues. I've seen as high as 20% of the population has like pituitary tumors. And then when I tell my students or residents that, they're all freaking out. And they're like, I have a pituitary tumor. It's like, yeah, you just don't want that full body MRI because it's probably going to freak you out. But in this case, you see that it's probably greater than 1 in 1,000 births. And so what's a Curie malformation? One is a herniation below that McRae line, and it's more than 5 millimeters of mercury, or sorry, more than 5 millimeters down. So let's do a quick review of CSF flow, because that could be involved in a pseudo Chiari, and maybe this patient actually had a pseudo Chiari, and maybe there was a misdiagnosis. Okay, so when we think of where CSF is produced, and I was saying this to Joe before we got on, it's remarkable to me with all the plumbing inside our body from both a vascular and a drainage standpoint, a CSF standpoint, that there's not more patients walking in with swollen nerves and all kinds of problems going on. So CSF is produced by the choroid plexus in the lateral ventricles, and then the roof of the third ventricle and the fourth ventricle, and then it drains, out into the subarachnoid space, and then it's actually drained superior sagittal sinuses, and we'll talk about that. So that's just a quick CSF review, and then what it's going to look like on a cross section on this sagittal MRI. Okay, so this is what we'll be looking at, specifically looking at the lateral ventricles. I think that's going to become very, very relevant. And then looking at where you have your cerebellum, and in this case, this is a normal cerebellum, but like what might happen in a Curie malformation. Okay, so with these Curie malformations, the thought process is this: in the posterior fossa, the occipital bone is underdeveloped, so it can't really provide a good structure for the cerebellum to hang on to. Okay, and so that it just kind of goes lower and it herniates because there's that set space. So you might have less space, and you have set volume, and you have a set size to your cerebellum, and so there's nowhere to go. So it herniates downward. Okay, and this can result in different symptoms. So if this patient had endorsed issues with like coughing or breathing, anything like that, then it may have been something that would have been cause for decompression of the foramen magnum. What happens with Curie malformation, one, is papilledema is very, very rare because it's usually localized if there's obstruction, and it's usually not really, really severe. Okay, but each case is a little different. That's why, again, we have to do neuroimaging on these cases. And again, you can always phone a friend, as we talked about earlier. So there's all kinds of different symptoms that can occur, and surgical intervention alleviates symptoms in 25%. What can happen is if there's too much obstruction, the spinal cord actually can't drain enough of the fluid, and you can get these cysts. And this just shows this area prior to decompression, and then post, eventually what will happen is this cyst goes away. But I think what's more important, I'm going to get to in a second, is ruling out that pseudotumor or IIH actually created a depression or a herniation. So major causes of increased ICP, and this is why we do neuroimaging, because even if we look at a patient clinically and make really good clinical assumptions, we have to confirm those assumptions. So there's all these things that can cause increased ICP. So ICP increase occurs in either an obstructive or non-communicating way, or a non-obstructive when there's just too much CSF produced and maybe not enough drainage. So all these things go in there, and IIH is one of those things. So the damage or the concern here is upwards of 20% of patients with IIH actually will have the cerebellar tonsils will descend. And so there's some cases out there in the literature, and God bless them for sharing, because it's kind of the oath that we take, is that we're going to share information. There was a case where they actually went in, said it was a Chiari, patient had bad headaches, and they ended up doing foramen magnum decompression, and lo and behold, nothing changed. They ended up saying, oh, oops, let's put them on acetazolamide, and the patient's headaches went away, and the tonsils actually ascended. It was a misdiagnosis. The patient had IIH the entire time. So we have to look at that from a neuroimaging standpoint. And this is not, I don't think, the purview of optometry. At that point, you would have already consulted with neurosurgery and a bunch of other professionals here. But I just warn you about things that can go wrong as far as looking at the total picture here versus like one snapshot in time. Okay, so what happens with IIH and why IIH is not considered to be hydrocephalus is that there's no enlargement of the ventricles. Okay, so you see normal ventricles right here, There used to be this thought process that the ventricles would be slit-like, but you can see in hydrocephalus here, and this is a shunt. This is a VP shunt on the right side. Look how big those ventricles are. They're just absolutely massive. And they do shunts a lot of times on the right side, because at worst case scenario, if something goes wrong, there might be motor function loss. But if they do it on the left side and something goes wrong, the patient's overall cognitive state is diminished because, again, it's the left side of the brain. So just food for thought. I'm setting something up here. So serial OCT, this is going to be exhibit B because Jeremy's case was exhibit A. So we're going to go with this timeline here. So patient comes in October 2022. She's a 26-year-old black female.
In my bag, in my car, buried in the bottom.
Okay, so yeah, we'll work off this. So you get this 26-year-old black female presents with increasingly severe and frequent right-sided headaches going on for 2 months. She's got transient blurred vision, not postural in nature. And I will say this, going back to history, I mean, sometimes you have to look. It's not like you're just on the front end asking these history questions. You're going to look at the nerve and then you're going to start asking more questions. Okay, so don't think for a second that I'm some magician where I'm looking at the patients and it's like, ooh, I'm going to ask all these questions on the front end. So she's on a high carb diet. We have access to all her information at the VA, which is awesome because we can put everything together comprehensively. She's put on 15 pounds in the last 6 months, and that's a gain of like 6 or 7%. I don't have my math together here. Current BMI is 36, no new medications, blood pressure is normal. She's on cigars, smokes some cigars every once in a while to unwind, some alcohol from time to time. And so let's look at the diagnostics. I'm going to move past this. I don't know why we didn't do photos. You can use multimodal with this multicolor on the spectralis. And all I want to show you is that when we go from deeper retina to more superficial retina, you can see that kind of C cuff really, really nicely shows up overall there. So just trying to explain the imaging we have there. Not as prominent on the left eye. And this reboot on the Friesen scale. I used to say Friesen, but apparently it's Friesen. I think he's French. I'd have to look that up again. And so with the Friesen scale, the one thing you're going to see first is you're going to see this C-shaped halo and then the temporal gap. And so what happens is your nasal, superior, and inferior tissue is going to swell because you have too much CSF, and it's going to go ahead and protrude anteriorly. And this is the one we're just looking grossly. So I can't look with an OCT and say, oh, the BML here is actually protruded anteriorly. And so what they've really started saying is you can memorize all these Friesen numbers, but maybe you should just look at it as I've got really not that bad papilledema versus like I've got bad or severe papilledema. And that may be a better way for us to actually delineate things. So again, we start out, we're doing FAF. And we're doing scans over the nerve because there's an outside possibility that she has a pseudo disc edema or pseudo papilledema situation. It could have been drusen. Let's look at our cross sections here. And again, we're going from temporal to nasal on our orientation. And you see that nasal is thickened right there. And again, you look at the reference database conversation, it doesn't really matter because you know that tissue looks strange to you clinically, and that's confirmed over here. And you know that's abnormal theoretically, but you'd have to track that over time. What's interesting about this case is that we talked about the flat BML or V-flat BML, and you can see that the BML on the temporal side is you're deflecting downward, as Greg said, and you have almost a flat configuration there nasally. So do we have some early changes going on there? And the answer is probably yes, when you look at over things. And then more of the same, where the nasal BML is starting to protrude relative to the temporal, but it's not pushing up in a very blatantly obvious way, so it's more subtle overall. The Hood report is again emphasizing that we want to put both the macular tissue and the optic nerve head tissue to better understand. The fields, fortunately, and you always want to do a field when you're looking for dysfunction. This isn't something that you can really track off Snellen. So her fields, showed that when you're putting her into the field machine and you're showing her those stimuli with the different brightnesses, her brain and her eye are communicating. The eye's telling the brain's telling the hand to push the button, and there's no sensitivity issues right now. So she doesn't have vision loss. So we say, hey, bilateral optic nerve head edema in the context of the patient with increased weight gain. She's got increased non-specific headache frequency. And we're going to say it's a presumptive diagnosis of IH, but we can't tell you it's IH. Just clinically, you need to do more testing. MRI, MRV within 24 to 40 hours. And she may need an LP. And then what we're going to do is we're going to copy primary care. We also did an e-consult over neurology. We ordered the MRI. And then we're going to bring her back for serial OCT. And you can take different liberties with how you're going to go ahead and bring the patient back based on the individual circumstances. When we look at the consensus IH diagnosis, and this is from Susan Mullen's group over in the UK, and she's done a ton of IH research and continues to do so. She's in Birmingham over in the UK, and some national health services over there, and they're constantly looking at ways to improve care and obviously save money and make things cost effective. So this is their consensus recommendation: is you want to have a really, really good ophthalmological and examination. That's something that we would have already done. So that's taken care of. You want to make sure that it's not malignant hypertension. And then you want to do pretty urgent neuroimaging overall. And then you're going to work your way through whether or not you do the LP. So when I order neuroimaging, I review the scans myself. I think, Joe, you hit on this already. And I think that there's different thought processes on this.
Drew, there's a question: does pregnancy influence the Chiari malformation?
I'm not aware of that. Joe, you have any idea on that? I'm not sure whether that's exacerbated by pregnancy. I think it would depend on the individual pregnancy. If you have complications like HELLP syndrome.
Yeah, it could. You can have increased CSF production, so it could in some instances. And there's a request. Go back to the last OCT. It shows why you think it's papilledema. They felt it looked flat.
Yeah. So I understand what you're saying. So I think it's almost like this is addition relative to subtraction. Okay.
Mm-hmm.
So when you look at the C-cuff always starts out, and again, clinically, this is a swollen nerve. Okay. So, we're going to look in and say this is a swollen nerve. And then the narrative that I'm putting before you is that there is a biomarker that's happening. So in theory, if I have a nerve that 360 degrees is about the same, but this slice is going temporal to nasal. So temporal here, nasal here. In theory, if I have a V, and I'm hoping who's asked this question, like this makes sense, that angle's pushing down, whereas I'm flat over here, okay? So the quote unquote V flat by itself, where you have V or you have flat, both nasal and temporal in the same plane, is under the auspices that's going to be the same. So what ends up happening here is you see what should be the normal configuration here temporally is not happening nasally. So what I am putting forth is that this is probably distended relative to what it once was. Now, here's the deal is I can't CSI my way back, but I would have to see that protrude forward to truly confirm my suspicions, because there's a very good possibility that you're right, that what I'm coming up with is very biased because I just read that article. Completely freely admit that. But I do believe, based on looking at this clinically, and you'll see how this case plays out as well. But it's a good point. So hopefully I answered the question on that. Did that make sense, guys?
Mm-hmm.
Yep. And again, it's just one slice too that I'm showing you. So you're going to want to look at all those slices. It's not like you're just getting a raster of one thing. You want to look at it continuously. And so I'm kind of, admittedly, I'm showing you what I want you to believe. So it's good for you to be skeptical, and you should always be skeptical when you're listening to these lectures. Okay. So let's go ahead and move on back to where we were before. So let's look at these neuroimaging markers, okay? Because we talk about biomarkers, and like you're going to order the neuroimaging. And I think, you have to make your decision, right? Do you trust neurology? If the neurology or the radiology rather, if their narrative or their impression makes sense with what your impression going in was, or do you double check everything? I think the recommendation generally is, hey, you probably should, but if you have a long-standing relationship with people like Joe does, and you've already had good communication, in theory, things shouldn't miss. I have a buddy, Chris Borgman, who lectures as well for OEC, and he has had multiple cases where maybe on the front end the context wasn't provided, on the back end something doesn't make sense, and that he's catching stuff on scans because he knows exactly where to look. So I think, again, when you order the test, you are responsible for the test. So if you're responsible for the test here on IIH, there are certain biomarkers you want to look at. Okay, so what we look at here on this sagittal here is you're going to see the normal pituitary gland. Now, what you have, and you always hear about, is this empty cella, where if there's too much CSF, it essentially smushes the pituitary gland, and you can't see that. And that can be a variation in normal if you have a huge cella turcica. But for the purposes here, an empty cella is not good. Okay, you want to look at what's happening with the nerve. A straight path is normal. But if you have a tortuous optic nerve, that's more consistent with IIH biomarkers. And these are all things we can look at ourselves. This is not overly complicated here. Now, we look at the globe, and the globe is in its normal kind of globe manner. And you look at the nerve as it comes in, and it looks like it's just this normal curvilinear process. And what you see here is you see that the globe is smushed. The other thing is, again, the subarachnoid space, if we have too much CSF, is going to show more hyperintensity. So you have CSF showing up in more intensity in these paraoptic subarachnoid space, and the globe is smushed. The other thing you want to look at is you always want to do an MRV when you think IIH. There's some studies out, and this is a paper that was done years ago in Indian Journal of Ophthalmology, where they found that 10% of patients actually ended up having some form of venous sinus thrombosis that were presumed to be IIH. And these were atypical cases, but it's worthwhile to do the MRV always. And the MRV can show certain biomarkers for IIH as well. So when we're looking at our transverse venous sinuses and the drainage, these are equal on each side. But on a patient that has IIH, specifically at the junction between the transverse sinus and the sigmoid sinus, you can have some stenosis going on there. So let's go to our patient. And then stenosis versus thrombosis. I say essentially on this side, on the left side, this is like the patient's going 20 miles per hour. And if it's venous sinus thrombosis, this is like everything's come to a halt. Okay, so one's a much more severe situation that you should have worse symptoms on. So let's go to our patient's MRI. So when we look at this, I'm going to go ahead and blow this up. You look right here, and you have your infundibulum there. You have your ioptic chiasm right there. You have your space above the pituitary gland. So is that partially empty? Probably not. This is kind of like going back to the BML. You'd almost have to see things to evolve for you to clearly say, oh, that's a partially empty. Radiology, when they looked at this, did not believe that it was a partially empty cell, and is definitely not an empty cella as far as that's concerned. You look at the nerves are straight. There's nothing weird going on there. Give you a different vantage point. Again, straight optic nerves, normal curvilinear globe. And then we look right here, in the paraoptic spaces on the coronal are not overly sophisticated here. What the radiologist says is, yeah, there may be venous sinus stenosis, but it's not really, really obvious. And when we look at IIH, bilateral transverse sinus stenosis is the most sensitive neuroimaging marker. So we don't have this on this case. So I'm going to kind of move past this 24-hour imaging because that's, well, let's do a poll question here, because I'm not going to get through the case. I'll just have to tell you how it played out to see. So the 5A club is something, a lot of us have learned. Larry Gray taught that to us at PCO years and years and years ago. And I think, when you guys have Dr. Lee lecture for you, I think he covers 5A Club and 6A Club. He's just a really, really entertaining, awesome speaker, just very knowledgeable.
Yeah, I think we're down to about our last 2 minutes or so. So if you want to land this one, if you have a lot more material, we'll bring you back for part 2.
Okay. I think what I want to finish up on. Okay. So let's just go through this then. Okay. Because I think this is an okay one to end on. Okay. So the 6A Club is where patients check in, but they don't check out. Okay. And this is why, if you have some of these entities, you want to manage those emergently because they could be life threatening. And so that's where the A's all come in. In our case, we have a presumed papilledema, and the recommendations are that you want to image them emergently. And you're rather, just like Joe said, you're better off imaging and over managing rather than under managing in conditions that could be life threatening. Now, what I want to say is the interesting way that this case played out is that serial OCT imaging showed, and you could see in the notes, her OCTs dropped off by, I think, 20 microns. She lost weight, started swimming again, and ultimately the decision was like, yeah, she has IIH, and she diet modified, and she had improvement of the tissue on OCT. So the OCT could be used as a neuroimaging device. And there's a lot more studies out where they're looking at getting CSF pressure, looking at OCTs to get an idea of what the Friesen scale number would be, and then subsequently determine whether or not they're having successful treatment based on the OCT. Because trying to do serial MRIs and seeing what's happening with the ventricles and other biomarkers is probably a little onerous. So it may be something, again, that comes more into our practices. So again, I think we had some really good conversation. I know I didn't get to anything, but are there any questions before we end? And again, there's a lot more material. I always have more material probably than I need, but I really like our sidebar conversations, and why I really appreciate people asking questions and Joe and Greg coming in, because we're kind of talking about this is what we might do in practice versus me just trying to dump a bunch of information on you.
I think that was great, Drew. There's no reason that it's always better to have more material because you don't want dead air. And the Rolling Stones don't play every song they know every show, so don't worry about that. It's how good was the show, and I think you edutained everybody very well. I thought it was engrossing and engaging. I really enjoyed that. So if you want to stop sharing for us, Drew.
Thanks, everybody.
Yeah, and it looks like all the questions were answered. So, Drew, thanks for doing this optic nerve retinal rounds from nerve-wracking to nuisance. And I certainly picked up quite a few pearls and a reminder of a few things that will help me certainly in clinic when I go to clinic tomorrow. And that's what Joe and I's goal at every presentation that we give or that we have someone come in. So thank you for doing that.
Thanks for having me.
That will end the CE for right now for tonight.